Good evening and welcome to tonight's webinar on tackling knee pain with Regenics. My name is Russell Burgum. I'm the physician and medical director at Regenics Des Moines. Tonight, our talk is going to focus on treating knee conditions, and I'm going to spend a little more of an in-depth discussion on the most advanced treatment for knee arthritis, intraosseous bone augmentation. And I will go over some groundbreaking research on that and discuss how we do these types of procedures here at Regenics Des Moines. Just a brief little background. I am a sports medicine physician by training. I'm board certified in sports medicine as well as diagnostic musculoskeletal ultrasound. And the large majority of my career has been focused on interventional orthopedics, and in the more recent years, interventional orthobiologics. And I will go over what that means in just a second. We will have time to have questions at the end if you have questions, and I'll also provide contact information for those of you who would like to come in for an evaluation or who have additional questions. So what are we talking about when I mention interventional orthobiologics? So the core tenets of this new medical specialty, which is pretty much about maybe a 5-10 year, maybe 15-year maximum specialty, is that we use injectates or things that we inject into musculoskeletal issues or damaged tissue that facilitate healing, particularly for tendon, ligaments, bone, muscle, or cartilage. And we use precise placement, use high-tech imaging modalities such as ultrasound or fluoroscopy to precisely place these injectates into damaged tissue or joints. And so just to give a little contrast of what interventional orthobiologics is compared to just your standard clinic that can do a joint injection. So on the left, we have the concept of doing simple injections, and 95% of US physicians will do a simple type of injection, generally not guided by any type of imaging device, and it's a simple injection injected into the joint. More advanced procedures would involve guidance such as high-resolution ultrasound or real-time X-ray called fluoroscopy. And about 4% of US physicians will do high-resolution guided procedures. And then 1% we would be considered interventional orthobiologics. Orthobiologics refers to not using cells or biologic products such as hyaluronic acid to inject into an orthopedic condition. So while there are 4% of physicians will use some type of guidance, when we interventional orthobiologic trained physicians do procedures, particularly at Regenics facilities, we don't just think about putting an injection into a joint and calling it a day. I look at the entire structure and look at what's contributing to the pain or instability or the degeneration of the joint. It's not just the cartilage wearing out, which is what osteoarthritis is. We look at what are the supporting structures doing? Are the ligaments and tendons holding up? Do we have laxity or degeneration in the various ligaments and tendons? And so on the screen here, I have examples of, for example, the hip, where some people might just put an injection into the joint. I would look at the lip of cartilage called the labrum, the iliotibial band, the ligaments around it. Similarly, on the knee, there's numerous support structures, numerous ligaments and tendons that we often will treat to make the whole joint more stable. And then over on the right, I have an example of shoulders. So what does that mean? Well, here are some examples of what's involved when we're actually doing an interventional orthobiologic procedure. On the left here is a fluoroscopy suite. This is a real-time X-ray machine, and it takes pictures like we see above here. This shows an example of a needle going into the joint, and the dark lines here is contrast dye showing that it's in the joint. This thicker line is called a bone trocar. This is what we use when we are doing intraosseous, meaning into the bone augmentation, where we're actually injecting into the bone to treat damaged or degrading bone, or to help the cartilage on the surface of the bone, which is down on this is looking at the underside of the kneecap, the patella. Putting healing factors inside the bone will help the cartilage grow on the surface of the bone. In this case, this is a procedure addressing this bright white area called a bone marrow lesion. Bone marrow lesions are areas where the bone is actually degrading or swelling inside the bone, and it's generally a precursor to rapidly progressing arthritis. And we can actually treat that and get that to heal and resolve by doing an intraosseous bone augmentation procedure. So when we're talking about knee surgery, if you or a family member or a friend is talking to surgeons about knee surgery, you want to make sure that they ask some questions and don't have an informed discussion. The big one is, are you sure that the knee joint is the source of the pain? It could be from the hip, it could be from the back, or it could be from the supporting structures outside of the joint. One thing that is not often discussed is, does the patient have allergies to metal or metal sensitivities? Because artificial joints use metal where we take out the end of the bones on the thigh bone and the shin bone and put in a metal joint. Some people have bad reactions to metals and can have an immune response. And do you have diabetes or pre-diabetes? Patients don't heal as well after surgery when they have diabetes. You're at a higher risk for failure from a surgical procedure. Have you tried supplements to help the joint? There are numerous supplements that have been shown to be helpful, including glucosamine with chondroitin, turmeric, fish oil, resveratrol. Big one is omega-3 oils. And have you tried a less invasive injection or procedure? So at Regenics, every procedure that we do is, one, it's backed by published research that shows this is effective. There are numerous research studies showing that platelet-rich plasma and bone marrow extract is effective and helpful for arthritic conditions, ligament injuries, tendon injuries. So fortunately, in 2005, the first Regenics clinic was the first clinic in the country to use bone marrow extracted stem cells to treat orthopedic conditions. They had the foresight at that time to say, you know what, let's track how long these procedures work and how well do they work. And so they set up a patient outcomes registry, a large database. Now there are over 100 Regenics affiliated clinics throughout the country and in other countries now that also participate in this registry. So what that means is, before a patient has any type of procedure done at a Regenics clinic, we ask them to fill out a pain and function and a symptom survey to get a baseline of where are they, what's your function level, what's your pain level. Then after a procedure is done, similar surveys are emailed to the patient, initially every couple months, then spreading out to every 6 months. By the 2-year period, they space out to every year. And you'll keep getting these surveys for up to 20 years, as long as you're filling them out and returning the emails. So we track that for every joint, for every type of procedure we do, whether it's a platelet procedure or a bone marrow stem cell type procedure, and in every location from head to toe. So as a result, Regenics has the world's largest orthopedic outcome database. And we use that as a baseline to see for a given procedure, let's say for knee arthritis, are you a good candidate for this? Are you a fair candidate or are you a poor candidate? So currently we're tracking 22,327 knee procedures in our outcomes database. And patients rate the improvement at 39% after 1 month, 51% after 3 months, 57% at a year, and 60% at 3 years. And their functional rating, if their baseline data shows that they rate their function at 56% initially, that increases to 67% by 1 year, 67% by 1 month, 73% at 1 year, and 76% at 5 years. That data also shows a 45% pain decrease at 1 month. Now, this summary data is available on every joint that we treat, and it's available to the public. You can go to our website or any Regenics website, but if you go to regenexxdesmoines.com and look, you can see a section called Areas Treated, and you can pull up all the latest data from any of the joints that we're treating. So why will this type of procedure replace elective orthopedic surgery? Well, it's less invasive. Patients recover quicker. It's lower cost, and you preserve your biomechanics. You keep your own parts, and as a result of this enormous amount of data tracking how well it works, and also as a result of third-party institute analyzing our data and looking at how much does this improve the patient's quality of life, Regenics has been able to approach numerous corporations around the country who have self-funded insurance plans and shown them the data and said, here's our data. Would you like to provide this as a benefit to your employees as part of their health benefits? And maybe 4 years ago, I'd say we had maybe 400 corporations that said, yes, we will cover Regenics treatments done at a Regenics facility. Now there's over 3,000 corporations, anywhere from big companies to small companies to municipalities who will cover Regenics treatments. And really, it comes down to tracking your data and making sure you're doing the most thorough and scientifically based treatments. So when we talk about the procedures that we do, the main ones are platelet procedures called platelet-rich plasma, and the other one would be bone marrow aspirate concentrate, BMAC, which involves aspirating bone marrow from the back of the patient's pelvis, isolating the healing layers, and injecting them. And many people will say, well, you're using my own cells. Why don't these cells already go to the area of injury? Because platelets are part of the blood. Doesn't blood go everywhere? We have stem cells. They're called MSCs, mesenchymal stem cells. They're present throughout the body. They're not just living in the bone marrow. We have stem cells in our tissue waiting to come into action when there's injury. So when we use platelets, we take advantage of the fact that they become activated when they come into contact with connective tissue like collagen, such as like when you get a cut in your skin. It's a platelets that help stop the bleeding and form a clot. But platelets will release numerous growth factors once they come into contact with connective tissue. Some that will stimulate the MSCs in the area to become active. They'll release growth factors that stimulate cartilage cells to grow, tendon cells, bone cells, skin cells, or fibroblasts is a term for that. Then they also will stimulate new blood vessel growth into the damaged tissue. But one of the big things is that they will stimulates stem cells called MSCs to migrate towards the platelets. And there's another growth factor called transforming growth factor that stimulates those stem cells to transform into their final cell type. So the question is, well, why don't they get to my tendons or ligaments already? Well, skin has a great blood supply. When you get cut, you bleed right away. The platelets get activated, but tendons, ligaments, cartilage, they don't have a very good blood supply. They have a pretty poor blood supply. And so that's why we concentrate these cells and inject them where they're needed. And so this talks about platelet-rich plasma. I mentioned that we use platelet-rich plasma is the concept of where we draw your blood, we separate out the red cells and the white cells from your blood, and that leaves the plasma behind, and platelets will live in the plasma. So now if we take many vials of blood and extract the plasma with the platelets living in the plasma, we now collect all that plasma, and now we have a large volume of plasma with platelets all intermingled throughout the plasma. Then we extract those platelets and put them back in a very small volume of plasma. So we significantly increase the concentration and thus the dosage. And that is what we inject. And that's what's called platelet-rich plasma. And in Regenics terminology, we call it SCP, super concentrated platelets, because we can make that dose or that concentration much higher than what other clinics can do using simple bedside centrifuge type kits that they use to make platelet-rich plasma. So I mentioned there's numerous growth factors that platelets release. This will be this whole presentation will be available to you afterwards. If you want to look up these growth factors and dive in a little deeper, that's great. But these are the numerous growth factors that platelets release that we take advantage of. So when we talk about stem cells, what we're really referring to are things called MSCs, and there are MSCs and many other potent healing cells that are found in your bone marrow when we aspirate it from the back of your pelvis, and these can help repair tissue, and they act as sort of like general contractors that help direct all the healing cells in the area to help repair damaged tissue. And so a lot of people have said, "Oh, I've heard that bone marrow procedures are really painful. That there's a lot of apprehension about that." And I can honestly say that patients tolerate this procedure extremely well. So just again, as a refresher, we use bone marrow aspirate for more advanced conditions, for when patients have arthritis that's beyond where we think platelets alone would work, or if you have tears like in your knee, in the ligaments or the ACL, the anterior cruciate ligament, that's more than just a minor strain or a tear, we'll use bone marrow as it has more active growth factors. So this shows the tools that this in my hand here, that's called a bone trocar. Imagine a thick needle with a sharp tip that is attached to it's like a central needle that's removable. So you have a handle that I can hold on to, and we basically use this to bore into the bone. Once I get into the bone, into the back of the pelvis, I can remove the central piece. So if we pull this white part out, there's a port where I can attach a syringe on the end, and then slowly aspirate bone marrow from the back of the pelvis. And over on the right here, this shows what it looks like. It's a full surgical prep where I wear a surgical gown. The patient is prepped surgically with surgical soap and draped with surgical towels, and this shows bone marrow being aspirated. So it looks like blood. It's just a little thicker than blood, and the process itself is, like I said, patients tolerate it very well. Now, that isn't the case everywhere. One of the reasons why they tolerate it very well is the technique that we use, where we don't draw a whole lot of bone marrow from one spot all at one time. And a lot of clinics will do that, but at Regenics clinics, we've been trained to take little bits of bone marrow from several locations for the sole purpose of that technique. When you draw a small amount from several locations, we get the highest number of live cells, the highest number of stem cells. And and the reason why it hurts at other clinics is, one, when you draw a whole lot all at once, it's the pressure change that hurts when you draw bone marrow out. And so we're just taking a little bit at a time, and I spend more time just methodically extracting it from different locations. Going into the bone itself really doesn't hurt. So I do several a week, and every time I'm drawing bone marrow out from a patient, at least once during the procedure, I'll ask the patient, tell me what you feel right now, but what do you feel? And 19 out of 20 patients will say, I really don't feel anything. It's just maybe a weird sensation. And about 1 out of 20 will say, that kind of hurts. So don't worry about bone marrow aspiration. It's well tolerated. We also use light sedation. So we start an IV and give you a little sedative. You're awake, you can talk. But you're just a little sedated, and if you're having pain, we can push fast-acting pain medicines through the IV. So we do this to extract many of these various cells. There's also platelets in there. There's red blood cells in there, but we do this to extract these healing cells from the back portion of the pelvis, where I'm kind of outlining. So it's called bone marrow aspiration, or BMA, and the product that we get is called BMAC, bone marrow aspirate concentrate. So here shows the patients do this. We have them lying on their stomach. I come in to this area. This shows this. It says needle. It's actually a trocar going into the bone, and in the bone marrow is like a honeycomb appearance. On the outer edge of the bone is thick cortical bone, which has no nerve fibers, the cortical bone. The surface of the bone has nerve fibers. That's where patients can have pain. And so when I do a procedure like this, the first thing we do after you've been sterilized, the skin's sterile and prepped, is I inject a local anesthetic along the surface of the bone to numb up the surface of the bone. And this shows a drawing of a bone trocar going in to the bone and getting the bone marrow out. This is an ultrasound image from a procedure that I did just the other day. So ultrasound doesn't travel through bone, it bounces off of hard things. So this is the contour of the back of the pelvis. This is the bone trocar going in, and this is the skin up above and muscle. And this is somewhat zoomed in that the whole screen here represents about 2 inches in real life. So we're able to treat severe arthritis and help patients avoid knee replacement. So our outcomes data will show that even for severe arthritis, patients who they've been told they have bone-on-bone arthritis, they're still considered a good candidate. For milder arthritis, we can prevent it from getting worse. For more mild arthritis, we'll generally use platelet-rich plasma. We can treat meniscus tears. I treat ACL tears. People can have issues with the ligaments or the tendons, like patella tendon problems, and we treat all of them routinely. And oftentimes patients will get arthritis or degradation of their cartilage because they've had previous surgeries, like meniscus surgeries, where they cut out part of the meniscus, which is the shock absorber pads. So we can treat that very well. So again, this is really a 1.5 inch. I mentioned we have the 30,000 foot view. This is the 1.5 inch view. Here we are at about a 1.5 inch depth. This is a needle. It's a skinny needle, but I'm zoomed in, showing that I'm just about to inject bone marrow concentrate on the surface of the knuckle of someone's thigh bone. You can see how irregular it is, and a normal healthy cartilage would be a darker layer of like this, a thicker layer, and up here the cartilage is completely gone. So that's where we're putting the bone marrow extract. So we put the patient in a special position to flex their hip and flex their knee to get the weight-bearing portion. This is the portion where, when you're standing, is rubbing bone on bone. This moves the weight-bearing portion of your bone to the front, and I can inject right onto that. So the big thing, the most advanced treatment for arthritis is called intraosseous or IO bone augmentation. So we use that for moderately severe to severe osteoarthritis or OA. We also use that to treat bone marrow lesions or edema. So when this is an MRI image of someone's knee, the healthy bone is dark. Fluid, such as joint fluid or swelling in the bone, is white. So this big white area here is called the bone marrow lesion. Along here, I can see where there's breakdown of the interface between bone and cartilage. But our cartilage gets nutrition through the bone. So if we have breakdown of the bone or swelling in the bone, we have decreased nutrition flow to the cartilage. When someone has an MRI done, regardless of what part of their body, if we see a bone marrow lesion deep to the surface of the joint, that is a risk factor for rapidly progressing arthritis. And so there have been studies going back 15, 20 years showing that you can do intraosseous bone augmentation, injecting bone marrow or even platelet-rich plasma. But some of the bigger studies were injecting bone marrow extract into this area, and that will get it to heal. And there are good studies following this up at 1 to 2 years afterwards, showing that bone marrow lesion resolves after intraosseous bone augmentation. But the big thing is for arthritis, I'm going to go over some studies showing how well intraosseous bone augmentation works for treating severe knee arthritis. So with this, we use X-ray guidance called fluoroscopy and ultrasound guidance. I mentioned IV sedation, and there are many successful studies, and I'm going to go over some of the research by Dr. Felipe Hernago. So we do this because if you look at this chart, it's kind of busy, but the blue shows stem cell levels, MSC levels in the iliac crest, the back of your pelvis, and what happens with them when how they decline slightly, but not terribly over time. So on the left here is a 20-year-old person, and on the right here is an 80-year-old person. Now in the red, that shows what the stem cell counts are in the bone just under the cartilage level in your knee. And you can see there's a steep decline. And as you get older, the stem cells that are in the bone in your knee have decreased significantly. And so that brings up the point that osteoarthritis, we've often been told that it's kind of wear and tear arthritis. It's just wearing down the joint. But really, osteoarthritis involves degradation of the healing environment in your bone and loss of stem cells in your bone. So what this means is, yeah, people may have told you, oh, we hear that when you get older, you don't have any more stem cells. You do have stem cells. You just need more of them in your knee than a younger person. A younger person doesn't need as much bone marrow extract to treat a similar condition because they've already got more cells in there. But the older we are, the higher the volume that we need to use. So this is kind of busy, but it's, or I should say detailed. But what I'm just trying to show you here is the surface. This shows what the surface of the joint or the bone looks like. This is the cartilage, which is a smooth surface, and we have different layers of cartilage growth. And this shows an actual a slide of the cartilage. But deeper down is where the bone meets the cartilage. And if we inject bone marrow stem cells down deeper in here, those bone marrow stem cells stay there. And this is where new cartilage grows. It goes from deep to superficial. So one of the concerns is if you are injecting bone marrow extract just on the surface of the bone, or just putting it into the joint, which is what a lot of people do, it can get washed away. If you inject it into the bone, it stays there. And so the injection technique has a big effect on this washing out phenomenon. And that's why in our clinic, we put you in a position where when we put the bone marrow extract on the surface of the bone, we have you stay in that position for 5 to 10 minutes to give time for that bone marrow extract with the MSCs to adhere to the surface. But we treat the arthritis from the outside in, but we also treat it from the inside out, from the bone to the surface using intraosseous bone augmentation. So these are some drawings, some pictures that showing what's involved. Where do we do this? Where do we put that injection in? This is on the far right here. This is one of the typical bone augmentation devices that I use. So it's similar to what we use to draw bone marrow out of your pelvis, but it's a skinnier needle and it's shorter. So here's an example of actually from my clinic showing a patient with severe near bone-on-bone arthritis on the left. This is their x-ray from just last month. And this is a fluoroscopy image of the procedure that I did doing bone augmentation in that area. So like I mentioned, we can treat ACL injuries and other ligament injuries. And I'll go over that in just a second, but I wanted to go, again, you might not be able to read the fine print here on this study, but this is a large study on human bone marrow stem cell injection into the knee, and this was done by Dr. Hernago in France. He's an orthopedic surgeon in France, and it's an amazing study. So it was a study where they followed patients for 15 years, and a little background, Dr. Hernago is an orthopedic surgeon in France. He's been doing total joint replacements like hip replacement, knee replacement, ever since 1974. So he's getting close to retirement, but he does 200, now he's like I said, he's not seen as many patients, but he would do routinely 200 total joint replacements a year. So he has lots of patients with arthritis. So he did a study with 140 patients who had severe bilateral knee osteoarthritis, and they were coming to him to have both knees to have an artificial total knee replacement done. And he had a study for those who wanted to enroll where the patient would get one knee, have a total knee replacement, and the other knee, they would do the intraosseous bone augmentation injection. Just the injection. They would not treat any of the other ligaments. They would not inject into the joint, just purely bone augmentation. So you have 140 patients, all of whom would get, one knee would be an artificial knee, the other would be a bone augmentation knee. And they followed them for 15 years. And so if you're looking later and you want to look up the study, it was published in 2021. The information is there. And so what did they find? Well, the patients with the total knee, TKA means total knee arthroplasty. So that's the joint replacement knee. 20% of the patient rated their replacement knee as excellent. They had great results. And 10% of the intraosseous patients rated it excellent. However, 25% of the joint replacements said it didn't work or rated it poor, and only 1.7% of the intraosseous patients said it was poor. So after the study was done, 77% preferred the knee that had the intraosseous bone augmentation done over the knee that had the total knee replacement. So of all of these knees, 25 out of the 140 knees that they started with the bone augmentation eventually needed to have a total knee replacement. So it didn't avoid total knee replacement in all of them. And so that comes out to about 1.5% per year risk of the patient actually needing to end up having a total knee replacement. However, 21 out of the 140 artificial knees had to have a second artificial knee called a revision. So they had to have a more advanced surgery to take out the artificial joint and put in a new artificial joint. So they're what we call the conversion rate to surgery was essentially the same. And those who but the key is the people who had the bone augmentation, they felt that knee was better than the one that had done the total knee replacement. So this graph here shows the pain level. So pain scores of these patients. So the red is the knee that had the bone augmentation. The blue is the knee that had the total knee replacement. So at baseline, the patients rated their total knee replacement. The knee that was going to get total knee replacement, the pain was a little less than the other knees. So the bone augmentation knees starting off were a little more painful. And what we find is by about 7 or 8 months afterwards, the intraosseous, the stem cell knee was felt the same as the total knee replacement knee, which is interesting because when I do this procedure, I tell patients we expect you to see about 80 to 90% of your improvement by about 6 months, and it should keep improving and reach its peak improvement somewhere between 12 and 18 months after I do the bone augmentation. So what they found is that the red had lower scores, lower pain scores, all the way out to 15 years compared to the total knee score. So that's a really big study. So you have 140 total knees and 140 bone augmentation knees, and they followed them for 15 years. So that's great. So here are pictures. I mentioned how bone augmentation can make a bone marrow lesion resolve. This is from Dr. Hernago's study. He showed a resolving of the bone marrow lesion 2 years after the injection. So the thrust, like I said, of tonight's talk was about the bone augmentation. I spent a lot of time on that, but I want to spend time on that because it is an advanced treatment that isn't available at most clinics, but we do them routinely and we get great results. And so it is the most advanced non-surgical treatment for osteoarthritis, and it's available here. But so we also treat ACL tears. I just want to show, we have some good pictures of that procedure. And there are different types of tears. You can have a partial tear. You can have an ACL that's just kind of strained and lax, where the knee feels loose, but the MRI shows no tear. So then, like, surgeons would say, oh, there's nothing we can do. It's not torn. But even if that ligament is loose, we can improve that with an injection. So you can have a full thickness tear where the ends are still close together. That's a retracted tear, or a full thickness tear where the ends are totally separated. So we get great results with the number 1 and number 2. And if it's retracted, we'll tell patients you are a poor candidate for a procedure. So that ACL actually has 2 different bands that go side by side, and we're able to inject each of those bands using X-ray guidance called the fluoroscopy. This is a fluoroscopy image showing those bands being injected. We use fluoroscopy because ultrasound, we can't see far enough into the joint to get to the ACL. And then these are pictures just that from a patient I injected just last week. On the left here shows me where the needle is entering down towards the ACL. This shows some contrast being injected. And then on the side view, it shows the 2 different bands of the ACL have contrast. So we inject radio opaque contrast to verify that we're in the right spot. And then right after that, I inject the platelet-rich plasma, or in this case, bone marrow extract right through the same needle. So people may say, oh, I've got a meniscus tear. The surgeon wants to go all in and clean it up. And what that usually means, so this is the meniscus is a horseshoe-shaped shock absorber fibrocartilage pad. You can have little frays on the edge. You can have more tears, different types of tears. And we have one on each side of your knee. So under each knuckle of your thigh bone, the medial side is the groin side. So the medial meniscus, lateral is on the outside. And so that's what it looks like. And we have good results treating meniscus tears, provided that it's not the type of tear that's flipped up and causing your knee to get completely locked. That's if you have locking, that means they have to shave that part out and get it out of there. But we want you to keep as much of your meniscus as you possibly can, because shaving out or cutting out large parts of it sets you up for more early arthritis. So this is an injection I did just the other day, showing the needle coming in. These bright lines are the bones of the knee. In between here is the edge of the meniscus. This is a tear in the meniscus. and I'm injecting platelet-rich plasma into the injection. Sorry, into the meniscus. So there's generally three phases of looking at new procedures, and the very earliest phase or immature phase would be, hey, look at this great new procedure. This is great. It works for everyone. Let's treat everyone with this. And then as you learn more, you might say, this is great and it helps almost everybody. And a more mature knowledge of a procedure would be, let's figure out who is a good candidate. And that is what I want to emphasize, is every patient that comes into our clinic gets, for one, a very thorough evaluation. You'll spend anywhere between an hour and a half with me, because we do a very thorough evaluation. I look at your lifestyle, a lot of counseling about diet and exercise, and all the many different ways that we personally look at how to optimize your healing environment in your body, because all these procedures stimulate your own healing. So I spend a lot of time on, hey, what can we do with your diet to make your inflammatory environment in your joint less inflammatory and more conducive to healing? What can we do with exercise or diet or fasting or different things that will stimulate stem cell activity in your body? So you get a very thorough evaluation, but everyone at the end of the evaluation, I will say, you're a good candidate for fill in the blank bone marrow extract procedure, or you're a good candidate for platelet procedure, or I'll say, you're a fair candidate for this procedure, meaning we think you have maybe a 60 to 70% chance of success as opposed to like an 80% chance when you're a good candidate. Or I'll say, you're a poor candidate. Our data shows patients in general don't get great results with this. I recommend you go ahead and have surgery. Some joints, we have much better data. Knees, for example, we have probably the best data. Other joints, if your arthritis is severe, our data would say, go get your hip replaced, for example, or go have ankle surgery. So everyone gets a candidacy rating. So we want to make sure that you understand what the problem is, what the procedure is that we're doing, and what is your candidacy, and how good do we anticipate your outcome to be. And then we have follow-ups after the procedure, both by phone and in person, to make sure that if things are going slower, maybe we need to add some treatments. But the big thing is everyone is we determine what your candidacy is. So there's no questions whether I think this is going to be worth your time and money, or do I think you should go get your hip replaced, for example. Now, fortunately for knees, for those of you who are here looking for about information about knees, even patients with severe arthritis generally are considered a good candidate if we do the more advanced bone augmentation procedure. Again, when that's based on our data that we've been collecting over 20 years. And I mentioned, when I look at your overall health, we kind of move the needle up or down a little. For instance, smokers don't heal as well. So if you're a smoker, your candidacy rating is going to be a little lower. People with uncontrolled diabetes or uncontrolled metabolic syndrome, that affects your overall healing environment. And so your candidacy rating might be a little lower. And that's why we work on trying to improve those. And then you may be someone who's like in extreme great fitness. You do a lot of weight resistance training. You're eating a non-inflammatory diet. You have all these healthy lifestyle modifications that you've been already implementing. Those types of things can kind of tip the needle a little more to a better candidacy. So everyone's treatment plan and everyone's candidacy rating is customized. So it's not a cookie cutter type approach. So we do have time. We have time for some questions. And if people want to text questions or raise your hand and speak, we can do that. And if you don't have questions, I have the information here on contact information for how to get a hold of us. The most efficient way is to go to the website, Regenics Des Moines, because there's information on there about our procedures and about Regenics procedures, but there's a section where you can fill in the am I a candidate? And when you enter that information, our scheduling team gets that, and they'll reach out to you and contact you by phone and go over in more detail whether you're a candidate and work with you on getting you set up for an evaluation. Okay, hold tight here. We've got Dan has a question, and he'd like to. If you unmute yourself, then you should be able to ask your question out loud. There you go.
Sorry, I was just kind of wondering, what are people looking at for their out-of-pocket on average expense for knee? I have 2 bad knees.
It depends what your treatment is. For example, platelet procedures are way less invasive and way less involved and are about 1/4 the cost of a bone marrow stem cell procedure. If you're doing the full cord press, where we're doing bone augmentation, the bone marrow stem cell procedure, if you're paying out of pocket and if you're not part of the Regenics corporate program, can be anywhere between $9,000 and $11,000.
Okay, thank you. Because I know I've got like partial meniscus repair on my right knee, and I've got some osteoarthritis in my left.
Yeah, so whenever a patient is, I mentioned we have our thorough evaluation. I give you a candidacy rating, and then depending on whether you're a platelet candidate or you're a bone marrow stem cell candidate, then the next step is we have you sit down with Carrie Julin, our patient care coordinator, who also provides more information, because we have lots of handouts, because I talk about a lot of this stuff in person, but we give you a lot of things in writing, and she goes over what the cost is depending on how advanced of a procedure we're doing, and then she also works on scheduling that for you.
Okay, thank you.
You're welcome. Let's see, we have in the question section. Yes, someone said, sorry, I'm late to joining. I see this is recorded. Is it possible to watch the recording? Yes, everyone will get an email probably tomorrow that has a link to the presentation tonight, and people who've registered but were not able to make it also will have access. We'll get the same email with the link to the presentation. Let's see. Any other questions? Someone raise their hand. Let me see. It's Dan again. Okay. Dan, do you have a question? You can unmute if you.
Yep, sorry. I'm back again. So I have images that have been done on both of my knees. One is an MRI, one is an X-ray. Are those things that you guys can evaluate and look at if we send you our records?
Yep. Yep, we'll often do that. We have a system set up where we can actually, for most institutions, we can electronically transfer your MRI images, so you don't have to mail a CD or anything like that. And the like I mentioned before, if you go to the regenexxdemoines.com and there's a box to enter your information, our patient education team and scheduling team that's one of their things that they excel at, is they figure out where you've had your imaging studies done, and they either they start the transfer of those imaging, start that process, or they let our staff know, and then we reach out to them. There's a simple link that we send to the facility, so we can get those it's great to have them in advance, because then we can give you a ballpark about, once I look at your MRI, looking at your MRI and your X-ray gets me about, well, it gets us in the ballpark of whether you are a platelet or a bone marrow candidate. And then your physical exam, and again, your physical exam, every patient, when I see them, I do an ultrasound exam too. And so on ultrasound physical exam, I can see things that often don't show up on MRI. I can see if there are ligaments that are stretched or loose, but not torn. The MRI is a static image where you're not moving. So I do things dynamically. So with the in-person exam, that's where we really fine tune all these ancillary structures, all these support structures that might be contributing to either pain or instability. But the imaging gets us in the ballpark.
Okay, so if you guys are doing ultrasounds, does that mean your consultation, there is a fee?
It well, if for example, if you're they have different fee structures. Like, for example, when patients are seen with their insurance, if you have insurance coverage, we charge your office visit and the ultrasound exam to your insurance. If you're paying out of pocket, it's a flat fee for the exam that includes all the ultrasound exam.
So insurance will cover the consultation. I know a lot of this stuff is not covered by insurance. That's why I asked.
Yeah, insurance will cover consultation and ultrasound exam. If you needed additional X-rays, like most patients will come and they haven't had any imaging studies done, and we have X-ray here, so insurance covers the X-rays as well. But yeah, unless you're employed by one of the 3,000 companies that provide this as a benefit through their insurance, the procedures themselves aren't covered under insurance, but the office examination and any ultrasound or X-ray imaging that we do is covered.
No, that's good information. Thank you.
Okay, let's see. Okay, that should be it. So far, I think we've answered all of our questions. If there's anyone else who has any questions, you can either type them in or raise your hand. And if not, I think we'll wrap it up. So thank you for coming. And again, this will be available to you starting tomorrow, or at the very latest the day after. And then I encourage you to take a look at it, because especially the things like the research study that I posted on the 140 patients who had a total knee on one knee and a bone marrow injection on the other. It's good to look that up if you're into analyzing the data. And also, if you want to see any of my slides, or you can share my presentation with any friends that you may have seen. That's all good for me. So again, thank you for coming. Thank you for your time. I hope this was informative, and I hope I conveyed at least a sense of optimism, because oftentimes people think, oh, my knee is so bad that there's nothing they can do, but there is. And it's extremely rewarding for me doing these procedures, because I see how well patients do when they follow up. Now, that said, if you go to see anyone, if you go to see a surgeon, or you see a interventional orthobiologic doctor, and they say everyone gets 100% results, everyone does great, walk away, because statistically there's always going to be some people who respond better and some who don't respond as well. So there's always going to be some percentage of patients that, even though they get the most advanced treatment, they may not get the outcome that you're looking for. But statistically, which is the power of data, we collect the data. Statistically, even for severe arthritis, our patients do well, and we can help them avoid surgery. So with that, I'll sign off and thank you. Have a great weekend, and if you have questions, we have the contact information here. So have a good night. Thank you.